So welcome everybody to our webinar today, which is with the title Driving a Better Future in Healthcare Through Patient-Reported Outcomes, the H2O approach. And I would like to very briefly explain what H2O is. H2O stands for Health Outcomes Observatories, and the idea of the project is to empower patients with health data. So what and how will we do this? We will set up independent observatories in 4 European countries, in Spain, in the Netherlands, in Germany, and in Austria. And we will collect standardized outcomes data, and importantly, also patient-reported outcomes data in 3 disease areas: in IBD, in diabetes, and in cancer. And the idea is to collect these standardized data in an ethically and socially responsible way. So what will we need to do this? We will set up a governance model, a comprehensive governance model which will allow us to share and to collect the data in an ethically responsible way. We will build up the technical infrastructure to actually collect the data, and most importantly, we will also standardize what we will measure. And in terms of what we will measure, a very important issue is that we will measure something which actually matters to all the stakeholders, including patients. So we will ask patients and other stakeholders what actually is most important to them, what really matters to them, and we will standardize these kind of outcome sets. We will already take into account what is existing. So there are already a lot of outcome standards, and some of them have started to be implemented, but H2O will be the first initiative where we will implement such outcome standard on a large scale in Europe. We will start in the 4 countries, but we will extend to more disease areas and other countries later on, when we think especially about the sustainability of our approach. So the idea is really to create something which will be sustainable in the future, and where we will actually change and revolutionize the way outcomes are collected at the moment, to create more transparency and also better data, which could then be available for research, but also for clinical decision making, and also to really improve the relationships between patients and clinicians. And we really think that patient-reported outcomes are a very, very important part of outcome measurement, because we really would like to measure something which is really important for the patients. And therefore, we focus a lot on how we can actually do this, how we should measure patient-reported outcomes, why we should do this, and what the benefits really are of patient-reported outcomes. And that's why we have invited you today. Judith Baumhauer is professor for orthopedic surgery at Rochester. And Judy, you are an international renowned expert really in patient-reported outcomes, and we would very much invite you to give us a keynote talk here on the importance of patient-reported outcomes from your perspective, and how you have been using patient-reported outcomes in clinical practice. And I think that would be really important and interesting also for all the research which is going on in Europe, but also in other countries, where we try really to drive also the methodological standards in order to have a reliable and accurate way of measuring patient-reported outcomes. So over to you, Judy, now, and we very much look forward to your keynote presentation.
Thank you very much, Anya. I really appreciate being asked to do this, and I'm excited that about this H2O initiative. I think you really have outlined something that's going to be very exciting, and I'm on board. So any way I can help, let me know. I'm going to talk about patient-reported outcomes and how they influence the care that we provide to our patients. The only disclosure I would make is that I am on the board of directors for the Promise Health Organization, which is really focuses on patient-reported outcomes using an instrument called Promise, and I'll talk about that in a little bit. Just to give you the dessert before the meal, I believe that the patient is king or queen, and that patient-reported outcomes and patient-generated data is really critical to a number of initiatives that we just heard from Tanya, really for preventative health strategies, maximizing healthy behaviors, assessing and determining whether or not our treatments are appropriately improving patient care, and then to allocate healthcare dollars to treatments that are positively influencing the patients. Now, I'll talk a little bit about what's happening at the University of Rochester. So first, let's just get on the same page. Well, what is a patient-reported outcomes? Well, it's a health outcome that's directly reported by the patient who experiences it. It's not interpreted. It's not entered in by someone else. It's entered in by the patient, not the doctor, not the nurse, not the tech, but the patients. And this is my very best example. It's really a publication from 2008. It was a relatively simple project where the authors looked at patients and providers for a few questions. This patient population were patients that had breast cancer, and they wanted to know questions like, how important was it to the patient to keep their breast? Well, it was about 7% of patients thought it was important to keep their breast. Well, 71% of providers felt it was important for the patient to keep his or her breast. See that disconnect? That disconnect is not a good thing. The patient is king or queen. Well, how about live as long as possible? Well, the patient felt, 59% of them, that it was important to live as long as possible. Perhaps they understand that quality of life is more important than quantity of life. And yet the providers thought, 96% of them, that it was important for the patient to live as long as possible. Well, this disconnect or lack of alignment is really problematic in treatments. And we need to know what the patient wants in order for us to fulfill their needs, because the patient is king or queen. We always say, if you want to know how your patients are doing, you really just need to ask them.
Hi, how are you?
Hi, good. I heard 1 o'clock.
What's your last name?
Smith.
And your date of birth?
1176.
And who are you seeing today?
Minton.
And any changes to address, phone numbers?
No, it's all the same.
Still Blue Shield for insurance?
Yes.
And are you familiar with the health assessment on the iPad?
I'm not.
Okay. This is an assessment that your provider would like you to take. It's going to ask some questions about your overall health, as well as what's bringing you in today. So just read through the welcome screen and tap on begin, and then it's going to be uploaded right into your chart, okay? So you're all set.
Okay, thank you.
You're welcome.
This is what we do every single day here at the University of Rochester. We started in our orthopedics department and we've moved across our healthcare system. We're still folding this in, so there's still some holes in this, but we're trying to fill it in as quickly as possible. Once we see a patient, we get this patient-reported outcome information, it doesn't stop us from talking to the patient, getting their history, doing a good comprehensive physical exam, looking at the tests that we might have ordered or someone else might have ordered, such as x-rays or lab tests. And then through that information, we get a diagnosis and discuss a treatment plan options, whether it be, in my world, since I'm a surgeon, whether it be operative or non-operative.
So that iPad that you previously filled out gives me a little bit of information about you. I can learn a little bit more about how you're handling the care that you're getting, and how your physical function's doing, and how you are doing with pain. So let me show you what you told me.
Okay.
So as I click this button in Outcomes, here is your outcomes information. And it tells me that you're functioning a little bit better, and that your pain is getting better, and that you're able to deal with your injury quite well.
Great.
Yeah. We're moving in the right direction.
Feeling good.
That's perfect.
So in order to collect those patient-reported outcomes and be able to use them in understanding how the patient is feeling and functioning and share it with the patient via those visuals that you see on the computer screen, we needed to have a good outcomes instrument. And some of these are the must-haves for this outcome instrument. We needed a validated instrument that was quick to complete, not on the backs of the clinician or burdensome to our patients. We couldn't have it be costly because we can't afford it. We needed it generalizable and flexible, since we were going to do it in orthopedics, and we were also going to do it in the asthma clinic, and we were going to do it in the urology clinic, in the neurosurgeons' offices. We needed to be able to view it in the electronic records so that we had an opportunity as a clinician to see it, but even more importantly, to share it with our patients. And it needed to be searchable so that we could look at it from a research standpoint, aggregate the data, and get some answers to how best treatment might be rendered for treatment plans. So we landed on PROMISE, and PROMISE is an acronym for Patient-Reported Outcome Measurement Information System, and I'll talk a little bit more about that in just a second. But the other words that you see up here, voice, it also is a cute acronym for Validated Outcomes in Clinical Experience. It is the platform that we set up to be able to utilize this PROMISE instrument. We initially had a mantra: every patient, every clinic, every visit. And I used to say that with sort of a jubilant voice. But then the patients taught me it was like every patient, every clinic, every visit. And we realized we really needed to do delivery windows where we ask questions at the right time when it matters most to the patients and the clinicians in making decisions about care. So what the PROMISE is a 11-year, $100 million effort by our National Institute of Health. What makes it very unique is that it's domain specific and not disease specific. It doesn't ask about arthritis conditions or Parkinson's disease, but it asks about physical function, which are important to both of those conditions, as you might perceive. If somebody can't walk because their knee is arthritic, or they can't walk because Parkinson's disease impairs them, then the same symptom can be measured, and that's what's called a domain, or domain specific or symptom specific. It is standardized across these domains with a T-score, and what that means is we can actually compare between conditions, because this T-score normalizes it for us, if you will. You can follow your patients throughout a healthcare system utilizing this, and these questions actually produce validated data very quickly using computer adaptive technology and item response theory. What that means is smart testing. You ask one question and the next most appropriate question is asked, rather than asking a litany of questions that aren't appropriate. For instance, if you say I can run a mile, well, then you're not going to need to ask them, can you walk room to room? So within 4 to 7 questions, they sort of have you pegged. This just gives you a number of different domains, and they fall into a physical health, mental health, and social health, or biopsychosocial model. This biopsychosocial model is important in the University of Rochester because it was actually begun here way back in the 70s as a focus of medicine. So in orthopedics, we asked physical function, pain interference, how pain interferes with your life, and about depression, because we realized that people coping or dealing with their injury or illness is equally important as we walk through their care pathway. So orthopedics started this collection, if you will, at our institution. And then we marched around asking other departments and divisions if they were interested. Our next partner really was cancer. And they said those 3 instruments are important in cancer as well, but also anxiety. So we we had them add into their PROMISE package, as we called it, anxiety for their patients. Palliative care, or where the end of life assessments are done, fatigue was important. So they added fatigue into their promise package. Urology said patients with urinary incontinence really didn't get out much or felt uncomfortable in social aspects. And so they asked questions about their ability to participate in social roles and activities. You can see that these multiple domains, and this is just a small smattering of these domains, that there are really a lot of them, and you can dial into what the patient thinks is important, which is key. We recognize by a number of publications, and I'll just show you this one in orthopedics, that the mental health component has a stronger association with patient-reported shoulder pain than the size of the tear in their rotator cuff of their shoulder. So that's really important information, recognizing that we really need to think about their emotional health as well as their physical health. So since 2015, when we started, we've collected over nearly 300,000 unique patients and 3.5 million scores. These scores are primarily promise scores, but we've expanded to other patient-reported outcomes as we found that we needed to in order to understand our patients the best, or that our patients told us these are symptoms that they want to follow or issues that they need to deal with. It took about 44 seconds per domain. So to do the three, it took us 2.4 minutes. And as I mentioned before, on average, it takes about 4 to 7 questions. So it's pretty darn quick. Does patient-generated data help us like this? Of course it does. It empowers the patient, engages them, and activates them to become involved in their own care, share their concerns, and allows us to understand them better.
My name is McCoy. I'm a doctor.
What am I, a doctor or a moon shuttle conductor? I jumped every time a light came on around here. I'd end up talking to myself.
I'm a doctor, not a bricklayer.
You're a healer. There's a patient. That's an order.
I'm a surgeon, not a psychiatrist.
Look, I'm a doctor, not an escalator. Spock, give me a hand.
I'm a doctor, not a mechanic. I'm a doctor, not an engineer.
No, you're an engineer.
I'm a doctor, not a coal miner.
You keep saying that. Are you a doctor, aren't you?
I don't know.
Well, I am a doctor and a surgeon, and I like to look at the data as well. So I'm going to share with you how we use this data, and hopefully with a little bit of a patient eye towards this. We're lucky enough to have the New England Journal of Medicine ask us to write an article on patient-reported outcomes if they're living up to their potential. And we published this in 2017, sharing some of this information, and I'm updating you on some more. Well, first, I just wanted to show you what we show patients every single day. We click an Outcomes tab in our electronic record, and it pops up a graphic display. This graphic display on the x-axis is the date, so the date of their visit, and on the y-axis is their T-score. Now remember, a T-score of 50 is the US norm. Now we wanted to make this very easy to view and be able to understand it intuitively almost. So we put severity bands. The green is within normal limits, and the red is severe symptoms. I always call the green good to go. The lines that you see here, the red line is physical function, the green line is pain interference, how pain interferes with your life, and the blue line is mood. I'll just walk you through a patient seeing me in the office, and this is the first time I see them, and I diagnosed them with ankle arthritis. I treated them with some non-steroidal medication, arthritis medicine. I put them in an ankle brace, and I recommended rocker-soled shoes because some of those treatments, in discussion with the patient, help with pain and allow people to function better. And then I see the patient back. And when she came back, she said, I tried those things, but it didn't work for me. So my pain feels a little bit worse, and you can see the green line dipping in the moderate band. I'm not functioning as well. I'm moderately impaired with physical function. And the blue line says I have mildly sad about this. So we said, okay, well, it seems as though those non-operative things aren't working so well. So let's move to consider surgical intervention. So in discussion with the patient, she opted for an ankle fusion. Now you see this big dip in the red line, which is physical function, because I operated on her and she's in a cast and she can't walk on it. So she's really impaired from a physical function standpoint. But look, the green line, because she's not walking on it and in a cast, she really has minimal pain. And the blue line, we changed her mood immediately when she knew she was moving forward with her treatment plan. Then we transitioned her from being non-weight bearing to weight bearing. So now she's weight bearing. She has some symptoms because she's still going through her episode of care, but her pain is well maintained and her mood is still very good. And then we took her out of the cast, started some physical therapy, and here we are recovered with improved function, and she's in the green. That is an ideal patient course. And I just wanted to share how things go when things work out well. And I'll tell you what, looking at that data and using that exact same graph, here's what I think as a physician looking at patients. So if I look at the patient, the first time I see her, I realize, she's impaired. She has some physical limitations. She's having some pain and she's sad about it. So I hopefully have an opportunity to help her. Then if I see her in the later visit, as we saw before, in the old days, I wouldn't have it organized like this. She'd tell me she's doing well, but I'd still feel compelled to see her again. Now, if people are in the green, I let them go. Why return? Why travel the 3 hours to come see me? So that's great too. And we can push out these patient-reported outcomes so that patients can do them electronically, and we can manage how they're feeling and functioning from a distance if we need additional information about their care. We also look at their trends. In this particular graph and how we set this up is good, down is bad. So just looking at trends makes it an easy way to view things. If it's going up, it's going to be a pretty easy visit for me. And for the patient, if it's going down, it's going to require more conversation. And so I actually structure my clinics like that so that I can help manage my time and the patient's time. So the easy ones, I might see them and let them go, and then go into the patient that's going to require more time, so I have more time for that patient. Here's an example of a patient that's actually drifting down. This patient had a hip replacement and was in the green, good to go. And over the course of years here, has started to drift down into mild impairment. We wouldn't necessarily think that was the way that this should go. So maybe we have to look at, is this an indicator of some hip loosening, or is something else going on? So these trends can allow us to pick up things in patients that we might not have tracked previously. Now let's ask some specific questions, things that patients ask every day. I got knee arthritis. I'm thinking about a knee replacement. Will I be more physically active with surgery? Well, I got a physical function T-score of 47. Remember, 50 is the US norm. So what we do is we take some aggregate data. We take a bunch of patients, in this case, 118 patients that were going to be having total knee replacements. And we followed them along after their knee replacements for almost a year. And we found that patients who had a physical function score that was greater than 44.5 had an 88% probability of failing to get better a minimal amount. So this particular patient fell into this box, the sad face box, that really they weren't going to do significantly better with a knee replacement. So this conversation goes like this. The patient asks this question, and I report back to the patient, you're functioning really quite well. And the patients that we've tracked previously, you're actually too good for a knee replacement. So let's talk about other options. Remember, that's with physical function. Now, if we looked at pain, if that was the thing that was driving this patient to come see us for surgery, pain may be a different box. So you have to ask the patient what symptom they're hoping to change, just as we heard previously. What about questions like, there's different procedures to treat my problem. Which one is the best one? Well, we can look at aggregate data for different surgical procedures. And here's how this particular one for ankle instability sort of stratified out. Three different surgical procedures, and yet 3 different outcomes. And the lower one is actually the most expensive. So if the outcomes are similar, why are we spending the money on more expensive things? The patients are getting as much out of it with the other less expensive procedures. There are several different surgeons. Who should I choose? Well, we can actually track our surgeons' outcomes. This is 6 different anterior cruciate ligament reconstruction surgeons and their outcomes with promised physical function. Their outcomes are quite similar. But again, we look at their costs. Are their costs quite similar? You'd say, well, why does the surgeon want to have their outcomes tracked? Well, we want to have our outcomes tracked because you know what? We want the best outcomes for our patients. If one of my partners is doing this procedure better than me, I'd like to learn why, and I can change. When will I be able to go up to the go to the basement to do my laundry, go up and down stairs? Well, we can do this physical function snapshot where we look at these different activities that are up on the top of your screen. I've circled climbing stairs because that's what the patient's interested in. I dropped down a little line here that goes to this very small wording of up and down stairs at a normal pace. And I drop a line here and we realize over on the y-axis is T-score. Well, you need a T-score of about 42 to be able to go up and down stairs at a normal pace with little difficulty or limitation. Well, what does that mean to me as a patient? I don't know. Well, guess what? Let's go back to my ankle fusion patient. A 42 here drops down to this date, which is 10 weeks after her surgery. After she gets out of her cast for her surgery, I'll say to her, well, 10 weeks after you come out of your cast and implement physical therapy, you're starting to do pretty well. That's when you're going to be comfortable on average. So you can answer some of these questions in a relatively more concrete way. Now I'm going to caution you, and I keep trying to use the phrasing that you got to identify what the patient wants to track. So this is a bunion. This is when your toe deviates, and that the arrow, the multiple red lines here are where your foot interfaces with your shoe and rubs and causes irritation. Well, the patients don't have any pain in the summer when they're wearing sandals, but in Rochester, New York, where it's snowy in the winter, and they've got to get into closed shoes, that's when their problem lies. So if I see the patient in the summer, maybe no problem whatsoever, and they're in the green. But when I see them in the winter, it's more painful. So tracking requires you to understand what it is that the patient's problem is and what you need to do about it. So their problem is they can't fit into shoes comfortably. So here is this patient. I'm seeing them in November, where they're just getting into closed shoes or have been in closed shoes, and yet they're still in the green. Maybe I shouldn't operate on them because they're in the green. Well, I know they can't fit into shoes, and that's their problem. So I fixed this bunion and I pulled them back. Now, how do I know that they're having enough of a problem that they need surgery? Because I asked other questions that are patient-reported outcomes. And this particular question is called a PAS score, a patient acceptable symptom state. It says, can you live with what you have? And if you see that data point on the bottom, it says it's not satisfactory. So if they're in the green on the graph, and yet their PAS score says not satisfactory, it's a disconnect. So I asked the patient, what is it that's not satisfactory in a better language than that? And they tell me, I can't fit into shoes. And then I say, now I get it. Now I know what I can offer you and what options we might have. And so it generates a discussion. After surgery, when I fixed her, it moved to the satisfactory realm. Last thing I'm going to share with you is a little bit of predictive modeling. Here's just the schematic of the things that I just showed you. That the patient comes in, takes the patient-reported outcomes measures in the waiting room. We view it in the electronic record. We save it on a separate server, and we do some predictive modeling to be able to give that information back to the patient. This predictive modeling has also helped us with upstream screening to identify patients at risk to fall or to need additional services or whatever it may be. It helps us care for our patients better. So here's some of the practical uses of PROs that I just went over with you, and hopefully convinced you that it's a positive efforts here with patient-reported outcomes that I'm a nut about. And just like I said at the beginning, I think the patient is king or queen, and that patient-reported outcomes and patient-generated data and EHR data are really critical for these different reasons. And our UR initiative and PROs is really promising. So thank you very much for this opportunity to share this information with you. And I'm happy to answer any questions or now or on LinkedIn or wherever you'd like to ask me. Thank you very much.
Thank you, Judy, for this excellent presentation. I think you showed very nicely how valuable prompts and PROs are and why they actually are needed in the consultation rooms. And I think that were very good examples and very practical for everyone to see really the benefit of this. I see a few questions, and maybe we can go through a few questions now, and then there will also be the possibility to answer questions later, as you said, via LinkedIn, but maybe we can see what we have now. So there was a question, Jessica Jansen asked, thank you for the talk, it was very interesting. I was wondering how you decided which prompt to select, as they need to be sensitive enough to pick up the changes and need to make sense to patients, but also cover the range of the patients.
Yes, so thanks for the question. So first of all, the patient-reported outcome instrument that we use is PROMIS, as I mentioned. And that PROMIS instrument has many different symptom complexes. It's a general health status measure. And what we do is we ask our patient, what is it that brought you in to see us today? What is it that's bothering you? And usually they'll tell us a symptom that is captured with PROMIS. And so we manage that. For instance, one of the bad injuries to the shoulder, the rotator cuff, you'd say, oh, that's pain or function, but actually it's sleep. People can't sleep with that rotator cuff tear. And so we actually measure, in addition to some other things, sleep. And that allows us to track whether or not our treatment plans, like physical therapy or surgery, operative or non-operative, are meeting the needs of the patient. So I think you have to ask the patient what they're hoping to improve with. And then the instrument that you choose has to be something that you're comfortable with and utilizing. And we have just landed on PROMIS. And I have to say, we asked some anchoring questions too, like that past question. And we asked some general health status questions that allow us to anchor the PROMIS that's being collected at the site of service to that site of service timeframe. So.
Yes, thank you. What I particularly liked about your talk was also the focus on the more generic measurement. And you explained that especially PROMIS, you would focus on specific domains rather than on disease-specific outcomes. Yeah? There is a question now in the Q&A tool, which actually asks whether you can give us a little bit of numbers or estimates how much of the PROMIS or similar PROs are already used in healthcare.
How much are already used? What? I'm sorry.
There's a strange noise sometimes. No, the question is whether you could estimate how many people, how many healthcare providers would actually use PROMIS tools.
Yeah, so in our healthcare system, we have probably 800 providers that are currently utilizing PROMIS. Across the country and across the globe, PROMIS is being utilized all over the place. And I guess I'll use a shameless plug to encourage people to look at the PROMIS Health Organization website to identify perhaps the places where PROMIS is being utilized in the world. So it continues to expand, and I don't know what the global numbers are, I'm sorry to say, but it's huge. On top of that, Tanya, I thought you were going to say the best part you liked was the Star Trek thing, but you didn't, so.
Yes, that was also great. There are a few questions on the reluctance or pushback by doctors, by the providers. So can you say anything about that? And I think we have been discussing a lot, of course. You say you track the individual surgeons. So I think it would be interesting, how do the other doctors, the providers, react if you ask them to do patient report?
Yeah, so I would tell you that not all providers are interested in collecting this. However, it's kind of a team sport. So as you can see, that if you have just one provider in a practice collecting it, it's not as powerful as if all of those providers collect it, because you can use that aggregate data to do some additional statistical analysis. So in our institution, fortuitously, the dean and the CEO of our hospital system supports this, and it's part of the strategic plan of the institution to collect this. So we've made it an important aspect. Secondly, providers who prickle, who are unhappy with getting it or whatever, I often think they're just it's kind of like your kid that won't eat peas. You know, it's sort of like just a challenge to me. I think, well, I'm going to show you why this is good, and I'm going to help you learn how to use this to expedite your clinic and to improve your interactions with patients. We've done papers, I didn't have time to present all this stuff, but we've done papers that recognize that collecting and viewing and sharing this information with patients actually improves communication and the patient experience. So what provider doesn't want to improve their patient experience or their interaction and communication with patients? I don't know of one. So I do it, I purposely comment to them that this is patient-centric, and I would hope that you'd want to be patient-centric. I think the last thing I'll say is people have fear. Surgeons worry that one surgeon is better than the other surgeon. So it's not like we publish this out to humiliate surgeons. What we do is we keep it internal. We say, look, guys, here, are you guys interested in seeing who's doing the best? And they all say yes. And then we do it for them, and then we hand them the data back. And what they say is, oh, you know, I didn't realize that this particular operation didn't perform as well as the other operation. I'm just going to swap to that one. Or I didn't realize that my outcomes weren't as good as my buddy's outcomes. You know, let me look into that. So they want to self-regulate, but they don't want people to regulate on them. That's the last I'll say about that.
Yes, and I think that's really important to have this kind of use of the data, which is done in an, as we said earlier, in an ethically or socially responsible way also, yeah, and to really use the data for learning. And I think that that's a very important and perspective. Yeah. There's another question, and I think you touched upon that a little bit. Are PREMs, so patient experience measures, are also used in addition to the prompts that you showed?
Yes, in certain aspects, you know, it's not all the time. There are certain initiatives that are utilized. Just doing the patient-reported outcomes have improved the patient experience. So there's been a number of studies that have looked at that and demonstrated that. So we actually looked at that with patient activation measures and things like that. But now we've sort of moved off of that.
Yes, thank you. And there are a few questions on resources. So which kind of technical support is needed? And also someone asked about where you actually found the money to have this programmed and implemented, what you showed in the beginning, in the videos.
Yeah, so I saw the technical, what technical infrastructure. Tim Benson asked that question. You know, I have to tell you that you do have to have allocation of resources to do something like this. You can't do it with nothing. I can talk about Promise and implementation. Promise has some things already built into our electronic record, but across the world, there are other Promise centers, if you will, in different countries that can allow you to, they can help you understand how to implement this. But you always need IT services, just like with anything else. And there has to be some allocation of resources to an important thing like this. We did write an article in New England Journal about the cost of PRO, and that article goes over exactly how much it cost us to do our custom platform back in the day, but it also looks at some commercial vendors and stuff that you can purchase in order for you to collect it in your offices.
Yes, the resources are of course always important.
Yeah.
Yeah. It's one of the critical things, I think. There is another question on whether you use any anchoring questions like change assessment, like minimal clinical important difference or things like that.
So we use anchoring questions, but we anchor them to the episode of care that they're getting. So their site of service visit. And I showed that last question, which is a great anchoring question. And I tried to demonstrate how we use it. We also have some general health status measures that ask the question, for the provider that you're seeing today, compared to your last visit, are you better, worse, or the same? It's something like that. And that allows us to also track things and make sure things are going in the direction that we're interpreting correctly. Because you can imagine, when I showed you that graph of the simple ankle fusion patient, that was pretty easy to follow. But imagine if that patient also had back pain. So that back pain is going to influence that green line. So it's going to be a dirty line. It's going to be a line that has some variation to it because back pain is going to influence it as well. Is that wrong? Does that make it bad? No, it doesn't make it bad. We're treating the patient. So we need to treat the whole patient. We can't just treat the ankle patient. We need to understand that their back pain's a problem too. So understanding what the component of how much the ankle is influencing it versus the back. So you could imagine that maybe when they came in, that ankle fusion patient, when they came in, if they had these mild or moderate symptoms, and yet their task question says, I could live with this. Then my question to them would be, are there other things that are bothering you? Because you have a very bad ankle, but yet you think you can live with it. And they'd say, oh yeah, my back's killing me. It's probably, and I always ask them, I said, is it like 50% of your problem? Is it 90% of your problem? So you need to have a conversation. This information isn't just in isolation. It's a addition to how you're caring for your patients. So.
Yes, I think that's really important what you say, that it basically changes probably also the conversation and the relationship in the consultation groups. And it's really needed to talk to the patient and to have these insights. Yeah. So I think that's really awesome. Yeah, wonderful. So let me see whether there is anything else. Yeah, there's a question on the promise system, which is normed for the US population, and how generalizable is this norm? And maybe I can say that we will hopefully collect some data in H2O, and we have in mind, of course, to look into domain specific and also generic measurement. But I don't know, what is your perspective regarding generalizability of promise?
Yeah, so I do think that it was the U.S. norm that this was standardized to. I know that the Dutch, Caroline, is going to be publishing that the Dutch patient population is very similar to the US population. So the T-score of 50 fits their population fine. So I think you do have to look into, ask yourself these questions, or as a provider or statistician, is this the norm for your patient population? So I can't answer that for every place, but I can tell you that looking into it is going to be an interesting project, and it's already been done in a number of places. So if you're interested in doing that, you can just follow the methodology, and I think you'd be successful in answering that question for yourself.
Yes, and I see a lot of people who commented that it's very good to treat the whole patient and to look into what is behind all the symptoms and findings. And I think that's really an important issue. And we have also discussed recently that it will probably change the way how you deal with patients, and to a more holistical perspective, actually, yeah? If you use patient-reported outcomes in consultation rooms. Yeah? I think, Judy, we have 2 more minutes, and I have a last question to you. So you said you will help us in H2O, and you will support us, which actually is a very good thing, and we will of course accept this and use your great expertise. So do you have any advice to us in the H2O project? Because I think it's very close to what you have presented, and much of the things you have said are very close to our heart and what we really want to achieve with the project. Do you have any final advice for us here now? What we should try to keep in mind?
I appreciate the question. I have to say, one of the greatest things that I've learned, I do research, and I'm very interested in nice projects and organized projects and things like that. But with patient-reported outcomes, you have to be a tiny bit flexible. You have to realize that sometimes you make with your best estimate, asking patients, asking clinicians, understanding what perhaps might be needed. And then you start asking those questions and you realize you didn't hit the mark, that you could do better. Don't be afraid to change. Don't be saying to yourself, oh my gosh, no, we have to go through this for 5 years and then look at the data at the end of 5 years. Don't do that. Be nimble enough to change, because really it is about the patients. It's not about our research information or anything. It's about centering around what they need to improve and what they're feeling and functioning. And if you pick the wrong instrument, somebody who asked, what instrument do we pick? If you pick the wrong instrument, guess what? Change. It's not, it's about making sure that you're serving the healthcare needs of patients and the patient populations. That's my best word of advice.
Yes, thank you. That's a very good advice, I think. And also, I like the way that how you phrase it, that it's really of trying something and maybe learning from this experience. So that's a very good approach, I think. So thank you very much, Judy, for being with us, despite that it's really early morning for you and you have a full day of clinical work in front of you. And you will join us again a little bit later. We have a larger break now for everyone to relax a bit and maybe do some other work in between, and we will reconvene at 2 p.m. Central European time again for the panel sessions. And I think we really have learned a lot from what you have explained to us now, Judy, and we are very grateful that you have come and talked to us and took the time. And I would also like to thank you on behalf of the whole consortium, and also Menis Styliadou, who is the industry leader of the project, for being with us and giving us all your important insights. And we really hope that we can count on you, and you will follow the progress of our project, and we can come back anytime later to you when we have a question or need your advice again. So thank you very much.
Well, thank you. I think we'll be learning from you. So thank you very much, and have a great rest of your conference. And if I can hop back on, I'm actually in surgery. So if I can hop back on, I will. But we'll see how it goes. Thank you.
Thank you.